think we have a good forum there.
Yeah, looks like we're live streaming as well. So I'll go ahead and get started. So welcome everyone back to UCSF's Cardiology Grand Rounds. I'm honored to present today Dr. Jennifer Cowger. Dr. Cowger is a heart failure specialist at Henry Ford Hospital in Detroit, Michigan. She's the section head of the Advanced Heart Failure Program there, as well as medical director of the Mechanical Circulatory Support Program and co-director of the Cardiac Intensive Care Unit. She's also an associate professor at Wayne State University. She completed her cardiology fellowship at the University of Michigan, as well as a master's degree in statistics there. Dr. Cowger focuses on caring for patients with cardiomyopathy, especially those with sarcoidosis and amyloidosis, as well as patients who have received either a heart transplant or LVAD. Her research focuses heavily on LVADs, specifically examining device complications and identifying predictors of long-term survival. She has served in multiple leadership positions in professional societies, including ACC, HFSA, and ISHLT, where she ran the MCS registry and has been on the board of directors. With that, Dr. Cowger, welcome. I'll hand it over to you.
Thank you. And thank you so much for inviting me here today. Certainly here in Michigan, where I think it was 20 degrees outside. I am jealous, even though it's not quite as warm and cozy there, I hear, as it usually is. I'm certainly jealous that I can't be there today. So usually I give a talk on, RV function or LVADs, but I just decided to change it up a little bit and go through some cardiogenic shock with really a focus on the microcirculation, which I think is something that's underappreciated in our field, at least at this point. And just, my background, so I'm older than a lot of you that look like you're on the call today. And when I trained, we didn't really have, we had Impellas, but it was the Impella CP or even the 2.5. And a lot of those cases went on surgical, into the surgical ICU, and all the ECMO was in the surgical ICU. So what they did to train us is we worked with surgeons as advanced heart failure and cardiology fellows, and we ran it on their service. And, I learned how to do cut downs for cannulation. And so I learned a lot from surgeons who kind of deal with cardiopulmonary bypass and the intricacies of ECMO management. So hopefully we'll kind of share some of the knowledge here today. Disclosures are there. Since I don't know if this is a CME talk, but I always put learning objectives in should you guys want to qualify for CME. So over the last probably decade or more, we've seen a marked decrease in mortality for cardiogenic shock. And I think there are a lot of reasons for that. Some are related perhaps to better patient management, devices, better education of some of the fellows and residents, as you guys are here on the talks here today. But, I think the important thing to do is look at these ongoing mortalities. And us in the VAD world are so excited because we got patients 58% survival at 5 years, and operative, our 1 year survival here is like 93% at 1 year after an LVAD, right? But, look at these survivals at just 30 days in patients with cardiogenic shock. So, while the field, I think, it should be happy and has many reasons to be happy, I think we need to frame our expectations in the fact that I think we can do better. And I think that that we need to learn more about the shock syndrome. So what do we know about trends in survival in the US? Overall, we're seeing survival improve. It's a variable survivals we'll go through here in a minute between the ischemics and the non-ischemics. But, it has improved, but, this is, what, 10, 12 years earlier, we're not seeing marked gains in survival despite all the technologies that we have. And there are a lot of reasons that I and others, and many others, have gone into looking at, why in clinical trial we're not seeing marked gains or improvements in survival. And some of it has to do with the fact that we weren't all speaking the same language in defining cardiogenic shock. And that's where in 2018, with a small update in 2022, the SCAI classification of shock came out. And, David Barron, who's now down at Cleveland Clinic, Florida, participated in this. And, they'll leave you and those of you that are in advanced heart failure see when we look at this A through E scale, this was really adopted using the concept of intermax profiles, where we're ascribing traits to a patient using some of our clinical knowledge to define them essentially as sick and super sick and very sick. And that was a start, but we learned some key things from subsequent studies. So this slide here shows the trials that were done after the release of the SCAI criteria using various cohorts or multi-center data that was put together looking at survival based on a patient's SCAI class. And the two things that come out are discrimination, which is the ability of a test or a moniker to identify alive from dead. And what you see from here is it's pretty good. So, B, or A is the dark blue, B is the more blue. And as you move up the line, you see that mortality increases as you go from A to E across most of these studies. But the discriminate or the calibration, which says, okay, if you're SCAI class C, you have a 30% mortality at 30 days. That isn't very precise, right? So just looking at the D's here, we have a mortality that's ranging from 68% to 35%. So discrimination is good, calibration is not so good. So then they started looking through the data and said, okay, what are we missing? Well, some of it's the usual suspects. So what are the patient-specific risks that really aren't captured in SCAI? The older you are, the more likely you are to die. Not a surprise. The longer you're in shock. Preoperative cardiac arrest, which is a huge risk factor. Myoetiologic factors. So what do I mean by that? Well, that's the difference between a prior normal heart and a guy who comes in with an AMI shock versus a chronic heart failure that has been pushed over the edge. And it's also the difference between single ventricle versus biventricular failure. Biochemical abnormalities, which we'll touch on here in a minute. And then I think, what Naveen Kapoor and the others have really touched on is the trajectory of your shock, which isn't a surprise, right? If you're getting better, your outcomes are better, but if your shock is not improving with management, then your survival is worse. So what are some of the predictors of mortality? I just show data here from the INNOVA shock study and from our group here as part of the National Cardiogenic Shock Initiative, just to really highlight the similarities. So the higher your lactate is, the worse your outcome. The lower your cardiac power output, the worse your outcome. If your organs are starting to shut down, the kidneys are the eyes to survival for many of us, the worse your outcomes. And then if we look at this in other groups like the cardiogenic shocking working group, they have a large cohort of patients, over 3,000. It's a mixture of AMI and non-AMI shock. So non-AMI shock actually is 52% of the cohort, which I think is nice because a lot of the studies were in cardiology were really initially AMI shock. Mortality inpatient was 35%, so lower than the old cardiogenic shock studies with balloon pumps in the early Impella studies. And what they found were, again, the key labs: the worse your lactate, liver dysfunction. Not surprisingly, if you're acidotic, acidosis and lactate kind of are going together. Hypotension on presentation. And an important risk factor is out of hospital cardiac arrest. And I think what is important as we go forward as a field is that we really need to really get away from lumping patients into shock versus not shock, and think about A, how severe is their shock, and B, what was their heart like prior to all this? And we saw this with one of the studies we did here, showing patients with non-ischemic or with non-ischemic shock or chronic heart failure shock, probably more appropriately called, tend to have better outcomes than patients with AMI shock. And we saw this in Dr. Kapoor's study as well, where your AMI shock here is in this reddish orange and your chronic heart failure shock is in black. And especially at the higher sky classes, mortality again tends to be worse for the AMI shock patients. So why is that? So what's the different phenotype? You know, the process of shock is one of you know, reduced organ delivery, but the phenotype of the patient is largely what's driving the process, right? So if we look at chronic heart failure and we compare that with AMI shock, what's the baseline heart structure? So patients with chronic heart failure shock come in with higher right atrial pressure. So the black bars are the chronic heart failure folks with shock, and the light gray or the lighter gray are AMI shock. So higher filling pressures, right atrial filling pressures, mean pulmonary pressures, pulmonary capillary wedge pressures. If you look at some other laboratories outside of cardiopulmonary hemodynamics, you see a few important things. They have lower mixed oxygen. So you're checking your PA sats, and the chronic heart failure patients have a much lower mixed venous sat than the AMI shock, but they're better at extracting oxygen. If you look at PCO2 content, that's a marker of anaerobic metabolism, and patients with chronic heart failure shock at baseline have more anaerobic metabolism. And in your mind, you would think, okay, they're going to be more acidotic, have higher lactate, et cetera. But what it is they actually are better at buffering this acidosis. And something that Dr. Cogswell says is they're facultative anaerobes, right? They've been living for so long with low flow that their kidneys and other organs have really adapted to this low flow state. So they're better able to handle these perturbations in the setting of shock versus the guy who was out on the golf course who has never been living with low cardiac output. And if he comes in with an AMI, can't necessarily handle that. And the reason why this is important is because as cardiologists now, increasingly, I can't make it out of the cath lab without hearing a CPO, a PAPI, RA to wedge, you know, all these formulas that are out there. And I always ask people to pause and say, okay, what was the heart like to begin with? And especially for PAPI, don't just give me the number of PAPI. I need to see what the PA systolic is, the diastolic is, the CVP, to see what numbers are actually driving these values, because we certainly can't lump a particular CPO value, in my opinion, for an AMI versus a chronic heart failure shock. And the data would support that as well. So if we look at AMI shock, a way to simplify it is that is more of a mechanical problem with a need to improve flow versus chronic heart failure shock. You know, yeah, the pump's not pumping well, but in many cases it's a volume problem. And this is kind of illustrated here. I love my pressure volume loop. So you have your normal pressure volume loop of a patient. The first thing you see here is if you look at this x-axis, this patient with chronic heart failure is functioning at much higher volumes than the guy who comes in with AMI shock. Their stroke volume is markedly decreased in the setting of AMI shock because they just can't generate it. But thanks to living with heart failure and Frank Starling mechanisms, they've dilated out their heart and they have a better ability, if you will, to preserve stroke volume. So one is a volume wall stress problem. This is very much an inotropic problem. So let's look at this in kind of case studies. So these are legit patients. So this is a 28-year-old, 6'8", so big guy, non-ischemic cardiomyopathy for 4 years. He came in nauseated, vomiting to an outside hospital as LFTs were up. And of course, you know, they're worried that his gallbladder doing well. His blood pressure is 110/80. His heart rate's 140. He's mentating, breathing fast. We compared this guy with a 5'6" guy. He comes in, he's had chest pain for 2 days because he's like, oh, it's just heartburn. Taken to the cath lab because of a STEMI. He's hypotensive, he's tachycardic. Both of these guys are mentating and they're oxygenating. They're both in some form of worsening renal function. LFTs are up, their troponins are variable up, and they both have the same lactate. So that's looking at the laboratory component of that, right? So now if we look at the echo, we say, okay, both of them have relatively preserved RV function by echo. This guy, not surprisingly, has a dilated out left ventricle versus the AMI patient. So when I look at a patient, the first thing I do is, in addition to looking at labs and perfusion, is say, okay, I need to support this patient. Both of these gentlemen are not perfusing their organs. They're sick. So how much support do I need? And I think this is particularly important because nothing is worse than putting, a balloon pump in and then having to call the cath lab back 4 hours later because the patient isn't adequately supported. So what I do in my mind is say, okay, let's just call out a cardiac index that's kind of on the normalish, so 2.3. If I take this guy's body surface area, what's his goal cardiac output? Well, this guy's 6'8", right? So his cardiac output is probably around 5 liters. Granted, it probably is not that high in the setting of chronic heart failure, but he's a big guy, right? On the other hand, this guy over here is 5'6", so he's my height. He doesn't need a cardiac output of 5 liters. So when we come to device selection, we definitely have two different considerations in terms of support. So if we think about support, we have our medical interventions and then we have our mechanical interventions. And I'm sure you guys are well versed in inotropes and the temporary support devices out there. For today, I'm not going to focus on inotropes. There have been plenty of studies out there, especially in the AMI literature, that have shown that inotropes really aren't improving survival. And a lot of that is because they're increasing myocardial oxygen consumption. But for our non-ischemic patients that are just barely tipped over the edge, that may be all that they need in the setting of low-grade shock, just to get them perfusing and diuresing. A lot of the negative inotrope data came out of some of the shock initiatives. This was a study from our group where we looked at 285 patients with AMI shock, and survival was reduced with each addition of an inotrope. And from here you say, is it the inotrope that's reducing survival? And I don't know. The argument is that you're increasing myocardial oxygen consumption, you're whipping a heart after it just had a myocardial infarction, you're not allowing the heart to rest. So that's one argument. Another argument could be that maybe the more inotropes you need, it's just the sicker the heart. So this is kind of like the shock, B, C, D, E path. And is it fully the inotrope after all? Probably somewhere, in the middle. But if we think about support, one way I like to wrap my head around this is kind of to understand the pressure volume loops. And I don't know if any of you have been to some of the talks. THT has really a great session with Burkhoff. It's kind of his baby, talking about pressure volume loops, and I've learned a lot in understanding how the different devices worked. And this is something that I think, is important to share with the fellows out there, even if you're not going to be going into, critical care or intervention or heart failure. I think it's important to understand how these devices work because they have different impacts. Interpreting this data, though, is understanding that you have a baseline status of a patient that's assuming, a constant blood pressure, a constant heart rate, a constant volume status. So there's a little bit of, a futzing, if you will, with the data. But I think the point being, let's just look here, right? So passive volume filling, isovolemic contraction, aortic valve pops open, you're ejecting, you're relaxing. So end systolic volume and diastolic volume. And here is stroke volume. So if you put a balloon pump in a patient, what are we doing? We are taking that patient, and we know that the beauty of balloon pumps, it increase coronary perfusion and they reduce afterload. What we have here is a reduction in afterload, but we have an increase in stroke volume. So what ends up happening is it's a plus or minus for reducing or quote resting the heart with cardiac work, because you're still maintaining the stroke volume for that patient. But for many patients, that may be all you need. The Impella, on the other hand, again, the transaortic valve device, what does that do? So let's look. This is, the pressure volume loop at baseline. We pop the Impella in. What's it doing? It's shifting the volumes all the way this way, right? So we're reducing LV volumes. We're pulling off volume, so we're reducing stroke volume. And unlike ECMO or a tandem heart, we're not retrograde delivering blood back to that aortic root, right? So we're not increasing afterload. So what does this all lead to? We're improving coronary perfusion. You're reducing wall stress, right? Because we're not increasing afterload. We're reducing stroke volume of the heart. And we're resting that heart and hopefully reducing cardiac work. So if we have our case comparison back, we got the tall dude who's 6'8" versus the 5'6" guy. We have some estimate of cardiac support that we want. Roughly, maybe this guy around 5 liters, maybe this guy over here by 4 liters. And a lot of times when I, talk with my fellows, I say, okay, how much support do you think this patient needs? And the instinct will be to say, okay, I'm going to take this cardiac output. Both of these guys have a cardiac output of 3.2, okay? And I'm going to add to that an average output of 3.5 from an Impella. And so we've got more than enough flow that we're delivering to this patient, right? We got 6.7 liters. But the response to that is actually it's not additive. And why is that? Well, it's because if we look at the pressure volume loop, we have just changed after putting in an Impella the patient's stroke volume, right? We wanted to rest the heart. We reduced the stroke volume of the heart. So you can't add the cardiac output pre and expect it to be the same post. What about the tandem heart? I don't know if you guys do tandems there. This is actually at U of M. What I started to grow up on is they were a tandem center. We still do tandems here. It's basically you make a interatrial septum cross and you're pulling blood flow out of the left atrium and then delivering it usually retrograde through the femoral arteries. What does the tandem do? As you can see here, you can turn up the tandem. You have a baseline cardiogenic shock patient. As you turn up the flows, you're reducing the patient's stroke volume because you're pulling that blood out of the right atrium and you're offloading essentially the atrium of the heart. But what you're doing, because you usually have retrograde flow back to the aorta, is you are increasing afterload a bit because of that retrograde flow. So if you hold things constant, you're going to reduce stroke volume, you're going to rest the heart, but there is a consideration of some increase in afterload. I've not found it to be clinically remarkable, but something to pay attention to. So what are our options for this guy? For both of these guys? Do nothing, unless they have major social issues or say active malignancy, et cetera, probably no. Impella, for this guy, I would be really nervous about an Impella 3.5 because he's 6'8" and he's got LFTs of 1400, I think it was. So I'm not sure that a 3.5 would support him. A 5.5 probably would. This guy over here is only 5'6". So he may get by with a 3.5. 5.5 again is an option. I don't think this guy, though, is at the point yet that he probably needs ECMO, but certainly should be watched for it. This guy, another consideration might be ECMO. So case 2, this was my case in, let's see, January. 20-year-old kid, minding his own business, has a cardiac arrest during a pickup game. CPR started, came in, recurrent bouts of VT, VF, hypotension, dropped an echo probe on him, and this is what we see. No prior cardiac history of hypertrophic cardiomyopathy. He was intubated in the field. He's hypotensive, as you can imagine, looking at that ventricle. He's a 6'1" guy, 200 pounds. So what are his options? Well, you're not going to fit an Impella in there, right? That's not going to fit into this poor kid's ventricle. You know, a quote easy option or a feasible option would be ECMO. So what are we using ECMO for? We're using ECMO to perfuse the organs. We're using it to try to reduce right and left-sided congestion, but we're also going to acknowledge that it's going to increase afterload. And if you see here at baseline, you've got a patient, and as you turn up the ECMO support, you see this increase in afterload to the ventricle. And that is what, individuals have taught us, the need for venting a ventricle is you get an increase in afterload and the heart still tries to be strength like Frank Starling, and you end up with increase in LV volumes. And the volume also is coming from, that transpulmonary flow, right? The blood that's going from right to left that's not fully drained from that right side, the Thebesian veins, etc. So this is where the concept of venting came in. So what are the options for venting back in the old days? And I can't remember where you trained, but we would do what's called facilitated venting. We would do either inotropes to help try to pop open that aortic valve and vent the ventricle, or well, we would add in an intra-aortic balloon pump. And it's not a bad thing. The balloon pump French size is small. But if you look at it classically with the aim to rest the heart, you're probably not resting the heart as well as you would, for example, with tandem or lava, which is left atrial cannula, or an Impella. And as you see here, you pop an Impella in, and now you're pulling those volumes down. You're pulling the afterload down. And this is kind of the physiologic concept of venting a ventricle. Oh, and I always forget I put these arrows in, and then I forget I put them in. So for this kiddo, your options are do nothing. Probably not. I don't know why I left that check mark there. An Impella isn't going to fit. So you have some options here of either ECMO to vent with a balloon pump, or you have lava ECMO. And what lava is it's left atrial veno-arterial ECMO. You have this cannula that's a big hose. It's like, I think 30 French. And you insert that across the interatrial septum. And I love it. It's like my favorite cannula in the world for patients that come in super sick and super volume up and super malperfused. Essentially what you're doing is you're pulling blood from the left atrium. There's a bunch of holes here, and they're big holes, so it's not a lot of trauma on the cells. And you're pulling blood flow from the right atrium, both in two places. And then you're putting it through an oxygenator, and you're returning it to the left side. So you got simultaneous drainage. Let's see if I can make this work here. And this is his cannula, and you can see the reason why you're getting red and dark is because you're intermixing that left atrial oxygenated blood with intermittently with that right atrial blood right there. Okay. So for this guy, he comes in, and his pressures are up everywhere. The ventricle's not moving. It's tense. He's got some significant pulmonary hypertension. He has literally almost no cardiac index at this point. We put him on lava ECMO, and what's really just, it happens so quickly as you drop down their filling pressures pretty fast. And hopefully improve cardiac index and organ perfusion. And you can kind of see this catheter. Oh, I gotta put on my laser pointer again. You can see the catheter here. And we have all these protocols in place to make sure that, you know, we're not moving patients and dislodging catheters and whatnot. So, you know, I brought up the microcirculation and, you know, my fascination with it in terms of what's going on in the setting of cardiogenic shock. And I think this is going to be our Achilles heel, because we've got a lot of really cool technologies coming out now. And I think the concern is that some of the impact or lack of impact on mortality is because of the syndrome of shock, as instead of just a blood flow issue, now we've got a metabolic issue. So let's kind of look at what our field has to figure out, I think, to have a really marked impact on survival with cardiogenic shock. So this paper by Weirden, if fellows haven't read it, get it. It's wonderful, a review of shock and kind of the pathophysiology of systolic and diastolic dysfunction. And most of us, when we get a patient in, the first thing we're immediately thinking about is fixing the systolic dysfunction, right? So what does that do? You know, we pull out our temporary support devices of choice, whatever is your preference for the patient and or what's available at your center, and start working on improving perfusion. But in the background of all this, we have other fires that we start to need to put out before really things go in full flames, if they haven't already. And what we're starting to learn, what's happening at kind of a cellular level, is what's going on in terms of inflammatory cascade at the level of the heart. So some of the pathology is related to myocardial cell death. So there are these molecular cell damage associated molecular patterns, so something called DAMPs. And when heart muscle dies, your immune system says, okay, you shouldn't have heart muscle in the blood, so I'm going to go in there and I'm going to clean up this heart muscle. And that, in the setting of an uncomplicated MI, is what brings, you know, the cells in, they eat up the dead cells, and then fibroblasts come in and you heal. Well, when you've got a massive myocardial infarction or massive leakage of myocardial cells, that and other things can really cause the inflammatory cascade to go haywire. And I feel like anytime you have a toll-like receptor, bad things happen, right? So you activate the toll-like receptors, and now we're stimulating the immune system. And we're not only stimulating, you know, just local cytokines, we're actually stimulating the marrow and the spleen, and we're releasing progenitor inflammatory cells into the blood. You've got your chemokines, your cytokines that are coming out, and basically it becomes a cat chasing its tail in terms of the development of the systemic inflammatory response. And what we know when you have SIRS with cardiogenic shock is your mortality is high. This was a study of AMI shock patients looking at those with and without SIRS, and just look at that mortality at 90 days and the MACE at 90 days for patients that had SIRS. And this is even in the setting of a normalized cardiac output. So you've fixed the blood flow issue, but you haven't fixed what's going on in the inflammatory cascade. And if any of you guys know Mandeep Mehra, he's a very intelligent man and very eloquent. And when he says something, it's always in this most beautiful, eloquent way. And in this article, when they were talking about cardiogenic shock, he said, we propose that the failure to improve mortality in cardiogenic shock, i.e. with temporary support, reflects an overly narrow focus on the hemodynamic alterations of the mechanism for systemic malperfusion. So that's the going on rounds talking about their wedge pressure and their cardiac index. And he's asking us to think about actually the mechanistic disease modifying model, where we're shifting away from focusing on cardiac output to understanding really what's going on at a metabolic level. And as Naveen Kapoor will often say, hemometabolic shock. So, they made this really beautiful cartoon saying it's not just about the heart, it's about all these other things. And these other things that are downstream are probably even more important. So what are those downstream things? So let's talk about looking very closely at the microcirculation. By definition, it's the terminal vascular network. Some people say it's less than 50 microns. Most agree that it's less than 20 microns. And these are the little itty bitty vessels that are in your target organs, your liver, your kidneys, your brain, your bowels. And essentially the job of the microvasculature is to feed the organ and to get rid of waste, okay? So if we think about a microvasculature, just because your mean arterial pressure and your cardiac output are normal, that doesn't necessarily mean that what's going on at the microvasculature is normal. So you have a healthy microvasculature up here. You have this stuff called the glycocalyx. And the glycocalyx is a lining inside of a normal vessel, and its job is to keep fluid within the vessel, and then cells will kind of diffuse in and out on their own. But when you have ischemia or inflammation, this glycocalyx kind of breaks down, it's damaged, and then things start to leak. So this is that patient that really just starts to puff up with extravascular fluid. And when there isn't oxygen being delivered to organs, red blood cells start to deform. They start to drop the oxygen on them. And then you start to activate your hematologic system, and you end up with microthrombi. And essentially, if you have fluid going out into the vasculature, you have red blood cells dropping their oxygen, you have ischemic tissue. And now what you have is you're not feeding the tissue, you're not getting rid of the wastes, and your target organ is getting malperfused with oxidative stress. So this is a really fun analysis kind of explaining this. And there's been a lot of research in the sepsis literature about this. And I think we have a lot to learn kind of from our critical care colleagues. There are 4 types of alterations in microcirculatory flow. But all 4 of these types are associated with loss of the ability to extract oxygen in different ways. Type 1 is when a red blood cell becomes stagnant and they lose their oxygen. And typically when you're going to see this type 1 pattern, you lose your ability to oxygenate the tissue, and essentially you're creating a shunt, right? So blood's going through and the tissue without oxygenating it. And that's most commonly seen in the setting of infectious sepsis. Type 2 is a decrease in oxygen carrying potential, and that can be because your patient has a hemoglobin of 3, right? They're anemic, or it's hemodiluted. So think of all of our advanced heart failure patients that just have massive volume overload. Type 3 here is RBC stasis. So the red blood cells aren't getting through to the tissue. When can that happen? It can happen in cardiorenal syndrome when your right atrial pressure is high. Or it can happen if you're clamping down and you're giving that patient, 10, 15 of epi, trying to get their blood pressure up. And what's happening at the microcirculatory level is everything's clamping down and you're impacting perfusion. And then a type 4 is your capillary leak, where you got your tissue here and your vessels there, and now that red blood cell has to go all the way down to the tissue, and you're just not able to support your organ. So what's the data for all this microcirculatory dysfunction? So what they've done is many centers that are looking at this in more of the basic science and translational way, especially in animal models, have looked at microcirculatory blood flow, focusing especially kind of under the tongue and the sublingual vessels. There are other vessels that they'll look at. And this is a study looking at normal microcirculatory flow. And if you just look at, septic and cardiogenic shock, look at the difference in the vessels here and here compared with normal. And, you see vascular occlusions, these vessels are cut off. You see shunting. And again, this is a failure from a multifactorial failure and largely a failure of autoregulation. So some of the data on this is a study of 14 patients with cardiogenic shock. Small study, but we're looking for pilot information. They looked at microcirculatory function, again, the sublingual, in patients that were pre-ECMO at 2, 4, 12, 24, and 48 hours after going on ECMO. They then categorized you as, were you weaned off of ECMO, of which 6 were, or did you die on ECMO? Now, importantly here, we're going to look at the macro circulation, right? No big difference in mean arterial pressure, okay? But what you see is a difference in microcirculatory perfusion and density. So the green is alive, this salmon color is dead. Small vessel density appears to be greater in people that are green, right? Alive. The perfused small vessel density, so those little guys that are actually getting blood flow through them, is greater, and significantly a higher percent of vessels are perfused. If you could not restore microcirculatory function to normal within 24 hours, patients were dying. It's another study, 24 patients, 15 alive, 9 died. ECMO blood flow or blood flow to the organs did not have a significant impact on survival. But if you look what's going on at the microcirculation, the more vessels you perfuse vessel density, that's what PVD is, the more likely you're to survive. And I'll skip this for time. This I thought was really fun. So it helps me kind of understand, where epi can help you and epi can hurt you. So these are pigs. They took pigs and they induced ventricular fibrillation for 5 minutes. Then they did 5 minutes of CPR, which is this lighter color. And then they shocked them out and they looked at microcirculatory blood flow. You see a drop in microcirculatory flow during VF, not a surprise. When you do CPR, and you do good CPR on pigs, apparently, you can improve microcirculatory blood flow. But that blood flow is not nearly as good as when you shock them out of their VF and you restore normal blood flow. They then gave some of these pigs, despite a normal cardiac output, they gave them epinephrine. And by giving the pigs epinephrine, it actually reduced microcirculatory blood flow. So if we translate this to kind of this diagram here, what you're seeing is flows are not getting to their tissue because you're clamping down. We're increasing the resistance at the microcirculation. If we look at the right heart, which is like one of my favorite things to study, and we've learned so much and respect so much about the right heart as bad doctors, right? Let's think about, what can happen to the right heart as we add mechanical support, temporary or permanent, to the left side to a right heart. So if you pre-device have a wedge pressure of 30, and you put on whatever mechanism you want to improve organ perfusion, you're reducing their wedge pressure, right? That's the goal. Well, that blood flow has to go somewhere, and where it's going to go is acutely to the right side. So if you have a right side that's either congested and or struggling, you're increasing your right atrial pressure, and that's a large basis of cardiorenal syndrome and some of these devices that are out there to treat the venous hypertension side of cardiorenal syndrome. And if, again, we look at the moniker of how this is working, this is, a type 3 microcirculatory dysfunction. You've got a really, really high CVP, right? So our resistance to flow is because of this high central venous pressure and high pressures on the target organ end. And for the kidneys, I think this is even more important because the kidneys are very much sponges. They receive 25% of cardiac output, but they're also a high capacitance system. So they really, really stretch out and they accommodate in the setting of congestion. And we see this when we're diuresing patients. They come in with an RA of 20, they put out 5 liters and their RA went down to 16 and then popped back up that next day because these fluids are just shifting, right? And at some point, if you keep on diuresing them, your RA pressure goes down. But in the interim, you know, we've got to pull this fluid out of either the gutters or out of the renal splanchnic system. So the transrenal perfusion pressure, kind of one of my favorite formulas, is mean arterial pressure minus CVP. And you know, as heart failure docs, we're always trying to reduce afterload, right? So that we can improve cardiac output. But when your CVP is high, we got to remember that, you know, not only is your right ventricle not going to enjoy hypotension, but these poor kidneys, they need perfusion. So if you make them too hypotensive, you're going to reduce transrenal perfusion pressure. So what we really need to do is focus on getting volume off of patients, whether that's with ultrafiltration or diuresis, while having a happy medium in terms of blood pressure. So, you know, that was a lot of science, and some of it probably right now is seen as voodoo, right? We don't have any large volume studies, but or large trials, but I think what it's telling us is a few things. One is, you know, when organs go down in the setting of cardiogenic shock, you know, we need to act fast, right? Because there's a point where if we delay, then the systemic inflammatory response is just going to go haywire. We need to restore cardiac output so that we feed the organs. And we need to treat hypotension when the cardiac output is low. I think the concept of understanding wall stress and afterload and what each of these devices contributes is really important. And maybe we can start personalizing some of our support for a given patient's pathology. On the microcirculatory standpoint, I used to be a big go big or go home component, but, you know, part of me pauses and says, you know, more flow may not always be better. There's some data out there, albeit very weak data, that maybe some pulsatility is good. So while we went away from inotropes in patients, for example, on ECMO, the question is much like durable LVADs. Well, maybe we need a little pulsatility so that the microcirculation is getting pulses of blood flow and everything's not pulling in the setting of SIRS within the microcirculation. Euvolemia is important due to the impact on the microcirculation and, you know, very importantly within the kidneys. And addressing the high right atrial pressures is probably equally as important as addressing the low cardiac output. And I think as heart failure specialists, we see this, we get on top of diuresis or ultrafiltration really, really fast. And that's something that I think we're helping our other colleagues understand, that just because you're hypotensive, that doesn't mean you stop pulling off fluid, because these high right atrial pressures are potentially as bad as a cardiac index of 1.2. So what are unanswered questions? Who's the futile patient? What's the best support for a given patient? How do we get outcomes better? Do we work with shock centers? Do we need to educate providers, EMS, ER docs on what shock is? Do we need to educate the patients? We definitely need better studies on temporary mechanical support. Because I think that while cardiac output and looking at SWAN numbers is key, I think that they're really not helping our aims. And in the interest of time, I'll skip kind of the expense of temporary support, but I think if you take the one home slide is total hospital care for a patient with ischemic and non-ischemic cardiomyopathy. If you add MCS, look at the price difference for these patients. And if you add MCS to transplant to 3 weeks in the ICU waiting for transplant, you can see how this is really going to be impacting our healthcare system. So we'll skip that. And that way we'll have time for any questions or discussion.
Thanks so much, Dr. Cowger. That was such a great instructive talk. I personally appreciated the cases you went through to help us have a framework to think about shock. So if anyone has a question, please feel free to raise your hand so that we can call on you. I see Dr. Redberg had a question or comment she put in the chat. I don't know, Dr. Redberg, if you're in a place to unmute yourself, if you would like to share your thoughts.
I think her comment is is beautiful, right? So,
Hi.
you know, these patients. Oh, there you go.
I'm actually in the conference room, but I couldn't figure out how to do it on the conference. Okay, so but that is my question. You're first of all, I remember Rebecca Coswell. She was a resident, so it was lovely to hear that you work. But you were getting a terrible. I'm going to end this. Yeah, I'm going to turn that off. Okay, I turned it off in the conference room. But my question is just what can we do to move forward and actually get randomized clinical trials? Because I mean, the physiology was great and you did an expert job.
Did you guys lose sound, or is it just me?
No, I think she came out, but to her point, for randomized trials.
Oh yeah, you know, I'll avoid my soapbox of industry and, you know, how in the world we've gotten to where we are with all these temporary support devices. And in fact, you know, we've changed our whole allocation system to now everybody's switching from 0.5 of milrinone and a swan to pick your temporary support device. And we've done all this in the setting of no trial data. Now, my colleagues in intervention will say, but, you know, we see this every day. Patients are doing better. They're surviving with their, you name it, temporary support. But we need data. These are expensive devices. They are not without their own risk. Some are certainly probably better for others, and some are probably better for some patients than others. And I'm not quite sure how we got in our fields, plural, because there's different fields looking at this, so far into utilization without sound data. There's a lot of discussion about, you know, how do you do this trial? If you got a patient coming in with shock, how do you randomize them to one device versus another? And I guess my answer to that is we have to do it. I think we've come a long way in coming out with the SCI classification so we can speak the same language. We've got more data on lactate and you name it. But we have a severe data deficiency here.
Dr. Klein, you had a question as well?
Yeah, thanks, Jen. This is a beautiful lecture, and kind of going to Rita's questions and to your answer even further, how do we not just randomize to one device, but what about two devices, right? I mean, you made a beautiful case that maybe instead of Impella, maybe you need an aortic and a Doria catheter or precardia, right, to address both sides of the circulation. So how do you randomize to two different devices in the same setting?
No, you're right. And that's the thing is, you know, first of all, we are all focusing on cardiac output. And, you know, honestly, if their patient's been at home and their lactate's 30, no matter what expensive device you put in, whether it's in an artery or vein or your tubes going into both, you know, you may not change the entire, you know, pathophysiology at that point. But you're absolutely right. All shock is not the same. Yeah, there's right-sided shock, there's left-sided shock, there's, you know, extreme shock, less shock. So these trials are going to be difficult. Endpoints are going to be difficult. I think that, you know, a 30-day survival endpoint in my mind is such an unfair endpoint. I want to know not only 30 days, but I want to know how they're doing it a year and 2 years, right?
Yeah, like what's, you know, you bridge them from shock to something else, right? But to what and how do they do afterwards, which may have been influenced by the shock. And to Rita's point, to medical arm as well, right? So pick the best pharmacological option versus one device versus two devices. Hopefully the shock network will facilitate that. And I know Sam has a question. Maybe he's going to bring that up.
Yeah, Dr. Brusca, did you want to go ahead and ask your question?
Yeah, I guess I wanted to take the discussion slightly further. And I think this gets in part to why some of these clinical trials have not been successful, which is patient selection, because clearly there are the patients, like your one example of the out of hospital cardiac arrest, 60s over 40s, where no support, there's really no equipoise at this point, I think, for no support. And the question really gets to, how do we predict the patients who are well enough with cardiogenic shock that they don't need the risk of a device? And how do we exclude them from the trials and avoid doing harm while focusing on the patients that clearly will benefit? And then how do we take those patients in the middle ground and predict which patients need support and which don't?
Yeah, and I think the other thing is shock is such a rapidly changing situation. A patient can come in and be stable and literally 10 minutes later, go into VF and, rapidly change. So there are a lot of hurdles in the field. My only concern is we need to start seeing better trends we do have better trends in survival, so I don't want to downplay that. But 30% mortality inpatient is it's really, really high.
Any other thoughts or questions for Dr. Cowger?
All right. Well, thank you guys for having me. This was fun. Hopefully I stirred up some discussion, and for the fellows out there, hopefully you aren't going to have bad dreams about pressure volume loops and stuff tonight, but I think hopefully that frames in your mind kind of a visual of what's going on. I know for the advanced heart failure fellows, those of us that write questions on the boards, that we love our pressure volume loops, so it's helpful to know those pressure volume loops for the advanced heart failure boards.
Thanks so much again for your time, Dr. Cowger. It was great to have you.
Absolutely. Have a good one, guys.
Great to see you, Jen. Thanks.
Great job.
Good seeing you.